Hello everyone. Today the topic of my exam preparation is eczema. In Urdu we can say jambal. Eczema is the group of skin condition in which we discuss red and the scale. You can see in the picture a baby in which characterize the skin basically, which is red and scaly. When we say eczema, we often means atopic dermatitis. Atopic dermatitis or eczema is chronic, means it takes times more than 3 to 6 weeks, and it is recurrent inflammation of the skin. Atopic means there is typically a genetic tendency towards the allergic diseases. Atopic dermatitis usually begin in the first few years of life, and it is often the initial indication that a child may later develop asthma or allergic rhinitis, means the hay fever. Other form of the eczema or dermatitis is actually the inflammation of the skin, in which we can study or we can discuss about allergic contact dermatitis, in which the allergen is present, irritant contact dermatitis, static, disquiet, and seborrheic. Okay, in the last three pictures we can clearly see the allergic contact dermatitis. The patient is allergy prone skin. Irritant contact dermatitis, in which there is something present, irritant or any cause or any chemical. And the last one is seborrheic dermatitis, in which there are 3 to 4 features in which in eczema we can discuss. Common manifestations include the erythema. Erythema is the redness of the skin. Scaling means dandruff, and vesicles means small pustules arises on the skin. Itching and lichenification. Lichenification is the cutaneous conditions caused by constant irritation of the skin, such as scratching or rubbing of the skin, which is more chronic. The burden of atopic dermatitis. It includes 3 to 4 factors. Atopic dermatitis affect as many as 1 in the 5 children. The major symptom is unbearable itch. The patient came usually in OPT, and the major complaint is itch. 86% of the children and at 84% of adults report interruption in the sleep and loss of sleep. Negatively impact. The person cannot handle the the uh, the social economical burden. 43% of the adults report the atopic dermatitis into depression within the last 2 years. Atopic dermatitis can affect attendance, work, sick leave, potentially job. Okay, atop eczema and the dermatitis are generally terms for the skin inflammation. In the skin inflammation topic, we may discuss eczema or the dermatitis, and use interchangeably, whereas the more specific subtype are underlying cause. Okay, and what is the clinical presentation of eczema? Eczema present with a typical clinical appearance and location at the differentiate. In the first, we can discuss an infant and the toddlers, means 0 to 24 months of age. In infants, eczemal lesions are more often acute than in adults and mainly located on the face and the extensor surface of the limb. The trunk may be effective, but the nappy area is typically spared. Okay, the differential diagnosis from the highest to low. The first one is atopic dermatitis, in which we can say eczema. And the second version is sporadic dermatitis. We may discuss. Sporadic dermatitis is a common skin condition that mainly affects your scalp. In this picture, we can clearly see the inflammation on the scalp of the skin. And the second one is actiosis vulgaris, are common inherited skin disorders that cause dry, scaly skin, often described having a fish scale of parents. Okay, the third one is scabies. Scabies is a contagious skin infection caused by the tiny mites that burrow under the skin, leading to intense itching and the rash. In eczema or in atopic dermatitis, the main concern of our discussion is itching. Phenylketonuria, PKU. PKU is inherited disorder that increase the level of substance phenylalanine, which mainly present in our meat, eggs, nuts, and the milk. And ectodermal dysplasia. Ectodermal dysplasia is a group of the genetic disorder that affect the development of the two or more structures that originate from the embryonic ectoderm, including the hair, nails, and sweat glands. And the last one is Netherton syndrome. Is a rare inherited disorder affecting the skin, hair, and the immune system. And the last one is celiac disease, only following introduction of gluten containing food. And the second one from the children and the adolescent from the age 2 to 6. First, we discuss about 0 to 24 months of age, and now we discuss 2 to 16 years of age. In this age group, polymorphous manifestation with different type of skin lesions are seen, particularly in flexure folds. Differential diagnosis from the highest to low is the tinea pedis. It's a common fungal infection, and it is very itch between the fingers, especially on the toe. Second one is impetigo. It is the infection of the superficial layer of the skin. You can see the highly contagious manifestation, inflammation of the skin, impetigo, and the perosacea. Perosacea is the same as the inflammation of the skin. And in adults age from 16 years and older, in this age group, black-unified and exhausted plaques, and often particularly at the flexures, includes the wrist, ankles, and the eyelids. Okay, from higher to the low, it includes in the differential diagnosis, it includes atopic dermatitis, allergic contact dermatitis, seborrheic dermatitis, atopic dermatitis, psoriasis, rosacea, cutaneous T-cell lymphoma, and the pilaris. In the cutaneous T-cell lymphoma, the inflammation starts from the T cells. You can clearly see the inflammation and the itching on the skin and the scaling and the erythema. It is also known as non-Hodgkin lymphoma. And atopic dermatitis, it includes the severe itch, severe inflammation of the skin, and the pilaris. It is a chronic skin disorder that causes pink, red, and the orange red scaly patches on the skin. Atopic dermatitis is the most common form of dermatitis and can be present in the four stages: non-lesional stage, acute, subacute, and the chronic. In non-lesional, the skin is clinically uninfected but has an epidermal barrier dysfunctions, as you can see in the picture. And in the acute, characterized by eczema. Eczema is the redness of the skin, vesiculation, and accompanied edema. Subacute, characterized by scaling and the crusting. And the third one is chronic. Chronic, characterized by dry, liquefied patches and predominant follicular impigmented. Darkened skin types are commonly likely to develop in the extensor distribution. The Absence of eczema can typically underscore atopic dermatitis, where severity in the darkened skin type with traditional scoring system. Lichenifications is meaning the thickened patches, plaques, nodules with scratching and rubbing. Pigmentation may be hypo or hyper. Hypo means low, hyper mean increased pigmentation on the skin. Before we meet the patient with the eczema, we must know the four clinical conditions, the clinical more four key parts about eczema. The obviously the diagnosis of eczema is based on patient history, clinical examination, and the number of differential criteria that may help to diagnose. First, main essential feature that must know is eczema, which is acute, subacute, or chronic. And what is morphology? Morphology means shape. What is a specific pattern? What is the location? And what is the condition of severe itch and chronic and the relapsing history? Important features in early age of the onset. Atopy means it is a genetic tendency towards the allergen. It is personal of the family history, raise IgE levels. It is immunoglobulins, antibodies that respond to the specific allergen. Xerosis means extensive dryness of the skin. Associative features in which we atypical vascular responses, keratosis pilaris, facial pallor, white dermatographism, delay blanch response, other regional condition, periocular and periocular lesions, perifollicular and the pleural lesions. And the last one condition may include, which may include scabies, seborrheic dermatitis, ichthyosis, psoriasis, cutaneous T-cell lymphoma. We already discussed in the last slide. Photosensitivity, immune deficiency, and the eczema. In the pathophysiology of the dermatitis, in this picture we have two different stories. In the normal skin, irritant, allergen, and the pathogen. Healthy skin provide a defense barrier and prevention penetration of irritants, allergens, and the pathogens in the dermis. Tightly packed keratinocytes forming a natural barrier. And in the last one, immune function, the natural defense mechanism of healthy skin keeps allergen contained. And in dermatitis, you can see the inflammation on the skin. Penetration of the irritant, allergens, and pathogens in the dermis result from a loss of the water and loss of lipid from the skin. Keratinocytes less tightly held together along easier penetration of irritant, allergens, and the pathogens, and the rapid dehydration which may result in dry and itchy inflamed skin, and evaporation, loss of water through the skin by evaporation. In eczema, the main concern is our the oil present in our skin, our sebaceous gland quality. In eczema, there are two main reasons. First one, the oil is not present in a good quality, and second was the barrier is disturbed. The complication in which we can face in eczema is the mental health problem, sleep disturbance, superinfections, bacterial, virals, and fungals impact on the growth and the development, social burdens, hay fever, allergic rhinitis, asthma, increased risk of allergic contact dermatitis, and food allergy. The first case of our lecture is Nadia Redface. Nadia is a 2-year-old infant who has been brought in by her parents, who is concerned by his rash. Clearly, a rash is seen on Nadia's face. The clinical presentation of Nadia There is a rash present on her face, especially her cheeks. A rash present on her trunk, arm, and legs. A rash on her neck. Okay, communication skill. Identify the likely cause of the rash will help to guide management communication with the parents and take through patient history is an important step. Of course, Nadia is a 2 year old. In respect of history, our main concern is the history based on or tell about her skin condition from their parents. Nadia present with a red rash over her face, neck and trunk and the limbs. Okay, she has been sleeping well through the night and have been very settled, but since the rash appeared, she has been irritable and unhappy and keeping the entire family up to the night with her crying. Dad has hay fever. In the family history, our positive finding is hay fever and asthmatic evidence of atopic dermatitis. No previous hospital administration, and there is a good conversation and communicational talk present between the Dr. Sam and her Nadia mothers. You can clearly see he asked about her rash, the onset of the rash, the associated features just like itching, and the onset of the rash. Yeah, how relevant is the father eczema and the hay fever? Yes, it is completely. It is very relevant because from the hay fever and eczema we can find the evidence of atopic dermatitis. Okay, very relevant. Oh yeah, the answer is correct. Nadia's parents are worried her eczema is caused by a cow milk allergy. No. Presenting complaint, in which we can discuss the onset, a description of the rash, itchy, burning, weeping, oozing, or the sleep disturbance, in which we can ask about the rash distribution has changed or stay the same, the worst affected area, and provoking factor in the summer versus winters or school uniforms because it is hard clothing or uniform clothing, the quality and the potency of the topical steroid used to date. And in the medical history we may discuss the birth and the feeding history, any other topic symptoms, any admission to the hospital because of skin, any other medical diagnosis, and the medication, any regular medication use we may ask, including the histamines and recent antibiotic, antivirals, or oral steroid used by the general practitioner, the current skin, including the shower bathing soaps, shower gel, and any other emoliate. We can talk about a medication history, any concern around the food allergy, and the family history. Family history is very important. Any first degree relevant with atopic dermatitis or any other dermatitis. And in the social history, we may ask any sleep disturbance, uh, sleep environment, co-sleeping or on bed, cold, dark, well ventilated, non-dusty, and any history of pets. Okay. On proceeding Nadia case, we finally reach on Nadia examination. A rash is a skin condition in which the color, appearance, and the texture of the skin changes. Okay, in which in examination we can determine the distribution of the rash, the color, and the surface texture. In this slide, you can clearly see in the distribution, the rash may be confined to a specific area of the body, more diffused or widespread. Color, yellow or greenish fluid. It may be red, it could be white patches, it may appear as white patches, and in surface texture, the rash may be flat or raised, forming small pustules like blisters. Okay, in the key features, we can see the rash on the face, the rash on the trunk, the rash on the neck. In clinical notes, dear students, you can see those things which may important to include in our history. The most interesting part of case discussion is MCQs. What diagnosis you may give? Nadia, I think atopic dermatitis. Oh yeah, it's good. The reason is present on the slide. Okay, moving. The key features of atopic dermatitis, you can see the scaly, erythematous, xerosis, signs of severe itching, skin-like purification, oozing. Involved skin is typically erythematic, xerotic, and scaly. Acute eczema may be oozing, exudative, wavy, and crusted. You may also see the blisters and small intact vesicles or the blisters in liquefaction. Small chronic patches of eczema become raised and lignified, thickened skin, and evidence of more severe scratching and itching. And the last one is the skin may be cracked. Okay, classical sign of atopic is the more allergy prone, the more evidential response of skin to the allergens. It may be the hyperlinear palms and the infraorbital fold, Danimark and infraorbital folds. It's very important, the at least major criteria and the minor criteria of atopic dermatitis. The two main and the two most important criteria of atopic dermatitis is the pruritus, is the means aging, and the dermatitis affecting areas, chronic or the relapsing, personal or the family history of cutaneous respiratory. And the two minor criteria, facial features, triggers, it may be emotional, stress, environmental, food, or skin irritants, complication, association of the complication, and early onset. Dermatitis in an infant, you can see clarity in the scale, cirrhosis, erythematous, and the barrier disturbance in these two pictures. One common inflammatory disease of childhood, age of onset, course, and distribution, and the aging. And the second one is distribution, same as itching. Aging may disturb the feeding and the sleeping patterns of the patient. Nadia management. Let's talk about the Nadia management. What is the following would you advise? I think so, emollients and the topical corticosteroid. And the correct answer, okay. For example, soap, foaming shower gels, wet wipes, hot bath, scented moisturizer, lotions. Emollient care is bath with the moisturizer, dairy flares, apply a suitable greasy emollient cream or emollient all over skin. Emollient care should be continued between the flares and ongoing basis to promote skin barrier function. In the topical steroid, we have Some major criteria: avoid irritants, minimize emollient care. First of all, we can use the face and then a 1% hydrocorticosteroid hydrocorticosteroid ointment for the 2 weeks, once in a daily, and after the 2 weeks, we can change on the alternate days. This is a most important, most useful in memorizing the atopic dermatitis treatment. There are four types of steroid present: mild, moderate, potent, and the very potent. Mild hydrocortisone, miconazole, fusidic acid H, fusidic acid B. In the moderate, betamethasone valerate, clobetasone butyrate is my favorite, and momentazole creams. In the very potent, betamethasone valerate, hydrocorticosteroids, fusidic acid 2%, betamethasone 0.1%, and very potent clobetasol propionate, in which we may describe Derma cream or the ointment. Recommendation: provide detailed information to the parent about medication use. Highlight the importance of keeping Nadia's skin from drying out. Recommendation: the use of the regular moisturizing bath. Suggest use of the cotton cloths, not woolen cloths, not so many warm cloths. Apply a soft layer of the cotton or any soft layer of soft clothes before wearing a woolen cloth. Recommend reduce contact with the dust mite and avoiding carpeting. Consider provide written information sheet for the patient. Okay, do you think additional pad testing should be arranged for Nadia? Yeah, maybe. The reason is patch testing may be important in certain pattern of persistent eczema. In the first few slides, we may discuss the relapsing of eczema. So for relapsing, we may be additional patch testing should be arranged for the Nadia. The key point in the Nadia case is that atopic dermatitis is the common cause of itchy rash in infants. The primary etiology factor is poor skin barrier. The main focus for treatment is the use of emollient to help treat dry skin. Due to poor barrier, patients are prone to the secondary infection. Parent education is critical to successful management. Okay, there is summary present in history. We may discuss age of onset, medication, allergens, and the family history. On examination, we may check oozing, erythematic, xerotic of the skin. And in the follow-up, most mild cases can be managed in primary care, but can consider referral for difficult to control or atypical cases. Okay, in the management, it is very important, to know the general principle of the management, because we are prescribing the steroid, the topical corticosteroid, which should be strong enough for long use enough, in which mild steroid can be used for the face and the neck, and on the flexors moderate can be used for the thicker skin, just at the limbs and the thinner trunks. Adequate amount of the topical steroid should be applied. Fingertip unit are rough guide. Allow the steroid to soak in before application of the emollient. Take note of the volume of the steroid use. Steroid sparing agent should be considered as the maintenance therapy. Okay, the session is pretty good in Nadia case discussion. Moving forward to our next case is Joey. He's a 19-year-old male, a nursing student. Okay, History of atopic dermatitis as an infant, but no dermatitis related problem since then. Okay, pretty good. Current medication, none. Present with the rash on both hands that appears 3 months after starting placement on medical ward. Because she is a nursing student, initially itching but now cracking and sore. Okay, you may see the clinical presentation of the Jewy with a rash on the palmar surface of both hands with prominent fissuring and scaling and journal eczema. Journal eczema means journal redness and the xerosis means dryness between her digits. What diagnosis should we give? It is irritant contact dermatitis. Yeah, okay, it's good. The detail of irritant contact dermatitis is sanitile signs present, direct toxicity, and sensitization. Okay, let's move forward. Meet Sarah. Sarah is a 24-year-old beauty therapist and has also been experiencing skin problems that she thinks are related to work exposure. She has been working in a beauty salon since she was a teenager and has recently retrained as a nail technician. Okay. No history of dermatological problem, but recently she has been experiencing cracked, dry, itchy, red fingers on both hands and no involvement of the eyelids and lips. Okay. Condition is not responding to 1% hydrocortisone prescribed by the GP. Okay. The clinical presentation of Sarah is present. Erythema xerosis fixings on the fingernail tips bilaterally, and cheilitis and the periorbital eczema scales and the xerosis, and the periorbital eczema and the scale. Okay, what is the diagnosis you may give Sarah? Is the allergic contact dermatitis. Okay, good. It is the type 4 delayed hypersensitivity reaction because she has recently trained as the nail technician. Acrylic nails, okay, and acrylic nails chemicals may be very potent to the allergic. The most important slide is irritant contact dermatitis and allergic contact dermatitis. In irritant contact dermatitis, the form of dermatitis caused by the contact with the substance that damage the skin barrier, and the allergic contact dermatitis, commonly known as ACT, is the form of the dermatitis caused by the allergic reaction. 1 to 4 type of the hypersensitive reactions occur 48 to 72 hours after exposure to the responsible chemical and improve over days if the skin is no longer in contact. We may arrange a patch testing for Sarah, which is suffering from allergic contact dermatitis. Basically, the first picture shows us the criteria and the presentation of the patch testing, and the other shows the result of patch test. It involves applying sample of the potential allergen selected by the physician to the skin on the back, typically on the Monday for 48 hours, and then removing the chambers on Wednesday. Then read all the 96 hours on the Friday, as the reaction can be delayed to the 96 hours. Okay, basically skin respond to the specific allergen, and it may look like a red, so with scaling, urticaria type. Okay, patch testing, negative reaction producing no skin change, doubtful reaction with the faint erythema or the redness of the skin, weak positive reaction with non-vesicular erythema infiltrating, strong positive reaction with vesicular erythema infiltrate, and the papules. In the Joy case, which he is suffering from, Chronic irritant contact dermatitis. Avoid all the potential irritant because he is a nursing student. He must be avoid all the potential irritant. Hand protector advice. Physiodic age or B emollient care and the barrier creams. Apply zinc oxide mixture cream, topical corticosteroid, systemic medications require intermittence. And the SARA, identify the allergen because he is a nail technician. Condition may change of role or the occupation, emollient care and the topical corticosteroid. While using the topical corticosteroid, we may divide it into two categories. First one is superpotency, can be used for severe dermatomes or non-facial areas just like hand. Treat less than 4 weeks. Second one on the 6 and 7 can be applied on the face, eyelids, genitals, and the area where skin touches skin. Treat for 1 to 2 week interval. Long-term management, use the least potent corticosteroid is effective. And the last one is medium to high potency, can be treated less than 6 to 8 weeks. Okay, while using the corticosteroids and the steroidal emollients or the creams or the oral, there may be the local side effect and the systemic. And from the local side effect, you may see the skin atrophy, stria, acne or the rosacea, hyperpigmentation. And systemic side effect, glaucoma, Cushing syndrome, hypertension, hyperglycemia, and excessive weight loss, telangiectasia. In the GUI patient advice, irritant and allergic avoidance is an essential component of managing dermatitis. Or in the MCQs, which of the following are potential irritant for GUI? Is antiseptic hand wash, sweat under gloves, and the word work. And what is the dermatitis? A scientific issue for Joey. He would not be able to tolerate the use of gloves. He may pose a risk to other patient. He is susceptible to the bacterial infection. Okay, Staph aureus, maybe. Contact dermatitis is common form of occupational dermatitis. Okay, patch resting is indicated. Okay, we require the topical corticosteroid. Okay, in the contact dermatitis, we may go history and examination, management, diagnosis, follow-up, recall, and impact. Refer if you patch test is positive, then we may involve the other medical team. Okay, the last case of this lecture is Steve itchy scalp. Steve is a 46-year-old male patient with present with severe dandruff and red scaly rash behind his ear. On moving forward, the medical history, no current medication, no recent hospital admission, severe dandruff and a red scaly rash behind the ear, forehead, and the nasolabial fold. The area is crested. He has extensive scaling of all his scalp, which is smartly itchy. Okay. Steve is married. His wife insisted her get the rash look at. Okay, the key point. Does you have this rash anywhere on the body? In the eczema, we may ask the patient about the distribution of the rash, the type, the distribution, the shape of the rash, associated features. Is disturbing his daily or the physical impact of the rash for the patient is present or not. And in these three pictures, the rash or the scaling is present on the view, on the scalp, on the face, and view of the eczema. Okay, in the second picture, the nasolabial fold are affected. In the third one picture, the axilla, and in first one, in the scalp, these features are present. Okay, in the examination, is that dermatitis is acute or the chronic? Acute means for the short term, chronic means for the long term or the mix. Is there any signs of the infection, bacterial soreness, oozing, crusting, pustules, or the viral? In viral, we may discuss small vesicle, punch out, eruptions. Is the patient systemically well or not? Steve differential diagnosis is psoriasis, ectopic dermatitis, seborrheic dermatitis, tinea capitis, rosacea, and the lupus. And what would you give Steve is seborrheic dermatitis? Yeah, the correct answer is seborrheic dermatitis. Here is the explanation about the correct answer, which is the seborrheic dermatitis. The etiology of seborrheic dermatitis is not fully understood. It may be the perforation or the Malaysia yeast, which is the yeast. This yeast Malaysia favorite food is oily skin. It may be seborrhea, oily skin, family history of the seborrheic dermatitis or psoriasis, immunosuppression mostly seen in the HIV presenting sign, and in the lymphoma, psychotropic medication, haloperidol or clobazam, Down syndrome, or in the stress history of psoriasis, treating with the UVA therapy. Yeah, the common presentation of seborrheic dermatitis is present on the eyelid. The eyelids may become red, swollen, flaky. We can see seborrheic blepharitis. Center of the face, it may affect the inner eyebrows, creases around the nose and the cheeks. Armpits, it occurs in the skin folds of the armpit. It often affects moist areas. The skin is pinky, shiny, with cracks on the upper chest. Well-defined round pink patches with mild scaling. And scalp, seborrheic dermatitis on the scalp ranging from mild flaky skin, dandruff, scalar, and sometimes weeping fresh eyebrows. On the face, it may often affect the inner eyebrows, creases around the nose and the cheeks. Ears, inflammation of the ear canal, which is called otitis externa. Upper back and some private area, and then the genitals. It may affect skin under the breast, groin areas, under the arms, or the fold of the skin or the abdomen. The skin is pink and shiny with surface cracker. Presentation of the seborrheic dermatitis in an infant. Yellow greasy scale on the scalp, a thick layer of scale often yellow to brown in color. Scale become flaky, easier rub off with time. In error, it may present with a salmon pink in the color, which is petal or the ring shape in skin folds, face hairline, chest axilla, inflammatory areas, groin folds. There may be diffuse scales on the scalp. It may be worse in winter and improves with sun exposure. It is mileage, very grassy scale, a combination of oily and dry skin. And in seborrheic dermatitis, we may often treat the symptom control. Symptom control is the mainstay of the treatment. Steve condition is medicated shampoo, mild to moderate steroid in combination with the topical antifungal keratolytic agents such as salicylic acid. Okay. Yeah, these were the emollients, olivine topical steroids runs to the affected areas, topical corticosteroid. Yeah, ketolytic, salicylic acid, urea. The longer the application, the better. Topical antifungal. My favorite one in my OPD practice is ketoconazole 2%. Topical calcineurin inhibitors. Tricholomers, which is my favorite one. Okay. Systemic antifungal. Itraconazole short course for 7 to 8 x 200. I usually give 200 mg orally once in a day or 250 mg. In which 2% antifungal, 2% ketoconazole is my favorite one. Okay. This is very explain or advise and reassure. Yeah, the most important topic we cover in this day one is relapse. Okay. Now, this 2-year-old girl who has been brought back to the clinic by her parents who may consent as she has been off for a few days and her dermatitis is worsened. Yeah, Nadia is our first one patient. Okay, Nadia is in the relapse. Okay, oh my god. Clinical presentation. The Nadia appeared unwell and fever is confined. She has palpable cervical and the lymphadenopathy means an inflammation infection is present. A cluster of small fluid-filled vesicle blisters also appear to each monomorphic. Monomorphic means all have the same pattern. Yeah, it may be the Staphylococcus impetigo, yellow cresting, or Staphylococcus, or maybe the cellulitis. In viral, it may be the MC, pox virus, eczema hepaticum. Okay, and then in fungal, it may be dermatophyte infection or the yeast infection. Then now the differential diagnosis is impetigo. And foot and the mouth disease, eczema, primary varicella infection, just chicken pox. Eczema hepaticum is dismantled. Viral infection characterized by the fever, cluster, or itchy blister, or the pinched out erosions. Then the diagnosis is eczema hepaticum. For confirm our diagnosis, we may give the bacterial swab culture and the viral swab. The reason is behind. But the eczema hepaticum is medical emergency that requires appropriate and promote treatment. The Nadia management plan is antiviral and the urgent refer. The reason is given below. Antivirals, valcyclovir should be instituted properly according to the patient age, weight, immune status, typically for 10 to 14 days until the lesion is healed. Antibiotic for the infection or the streptococcus, which may be typical flu. Topical corticosteroid, and it is referred because eczema hepaticum is a medical emergency. The key learning point You should know the impaired skin barrier in infants with atopic dermatitis make them prone to the skin infection caused by the herpes simplex virus. The diagnostic clues that fever, eczema, hepatic worm, can painful monomorphic lesions, as you can see in the Nadia face. Yeah, in which we cover the history examination, diagnosis for HSV1 and the 2 polymerase chain reaction. The management is the dermatological emergency, antivirals for the 10 to 14 days. IV acyclovir is required. Secondary bacterial infection is treated with systemic antibiotics. Impact and the urgent referral.